So as mentioned, I'd be speaking about mental health in humanitarian contexts, specifically touching on some of the countries that I've worked in, but happy to talk more about evidence from other countries as well, specifically some evidence that we reviewed both in my work at UNICEF, but also in the body of work that I've done across Harvard Chan School of Public Health and also the Harvard Medical School. So today I'd start off a little bit with speaking about what humanitarian crises globally constitute. This is something that's been receiving a lot of attention over the past decade. And we know that humanitarian crises have been increasing, and there's a large body of evidence about populations affected by humanitarian crises globally. And these could take on a multitude of forms. We have natural disasters occurring across the world, especially more and more now we're seeing with climate change. These could range from earthquakes, tsunamis, all sorts of natural disasters, but we also see man-made emergencies, specifically fires, crashes, conflicts, violence, and we also see the confluence of these in terms of complex emergencies. So, what we're seeing around the world with armed conflict, what we're seeing in terms of food insecurity and famine, which could be the result of many of these natural disasters and man-made emergencies coming together, have a huge impact on populations across the world. And humanitarian crises are increasingly posing a serious threat to the health and security and well-being of large communities and populations across the world as we get more globalized. So it's really an important topic that's getting more attention. I'll give some examples. These are sort of snapshots of some of these humanitarian crises we've seen across time. So the Nepal earthquake, which took place in 2015, which led to widespread destruction, and there was a lot of international aid and effort that went into rebuilding society. And this is specifically an area that's prone to frequent earthquakes, and we see that across countries in the world. Hurricane Matthew, which happened in Haiti, we've seen a lot of efforts, especially with the Harvard Medical School as well, a lot of sort of aid that went in to rebuilding society after the hurricane. And I'll talk specifically about the mental health consequences of a lot of these things today, but needless to say, apart from the widespread destruction, there's also been widespread mental health impacts of these disasters. One that I worked quite a bit on was the Ebola epidemic, which took place in West Africa. And we've seen with the COVID pandemic how much of an impact epidemics and pandemics and public health emergencies in general can have on populations, and how much they can impact both the physical and the mental health of people. I'll be specifically talking about some of the civil wars and armed conflicts that I've been working on. The South Sudan civil wars are they're really prominent. This picture actually became really famous. This was taken by Kevin Carter. This is in the Upper Nile region. It's depicting a young child who was, this is during the famine that took place in South Sudan, and a vulture sort of behind this child, and became really famous, but it also caused a lot of outrage about what's happening. The Liberian civil wars, again, these took place across several decades, but there was widespread violence, and I'll be talking a little bit about the weapons of war that we used, but they really have had long-term impacts on the mental health of people who not only went through the wars, but generations to come after that. And there's a lot about the intergenerational transmission of trauma through these wars. Also worked with populations who were affected by the Sierra Leone civil wars, which took place. Again, this is a picture which depicts a lot of the forced recruitment that took place. And I work specifically with former child soldiers, but this was, again, something that's been used more commonly, where there's forced recruitment and forced drugging of younger and younger populations. And that's, again, we're seeing more and more as, with the Ukraine-Russia conflict, with the Israel-Palestine conflict now, we're seeing a lot that's coming up in some of these themes across countries and contexts. So this is a slide from late last year, which gives the overall numbers of internally displaced people who've been affected by conflict and violence. And we're seeing that across the world, these numbers are rising. I have slides from previous years as well, and we're really seeing how much movement and mobility there is because of conflict and violence, but all of the other issues it raises around identification, around working with refugees, with displaced populations, and how that affects their health and security and also aid. So as I mentioned, today I'd be touching on some of the work that was done in South Sudan, Liberia, and Sierra Leone. But I've also done similar work in Rwanda, DRC, Somaliland, and more recently in Ethiopia. So happy to kind of touch on some of these examples as well as I go through this talk. So, because we're talking at the Department of Epidemiology, what I'd be presenting today is an overview of some of the methods as well that I've used to look at, specifically look at war-related trauma and how we can measure trauma, but how we also capture it across populations. The first is just some broad findings from a lot of extensive work that I've done in South Sudan. And this is work that I've done with the South Sudan Law Institute. And just to give a little bit of background, South Sudan is the newest country in the world, which became independent from Sudan in 2011. There was a conflict which began in 2013, primarily because of ethnic tensions and resources, military politics. These are some of the things that we see across contexts. These are some common causes we see across armed conflicts. Soon after they had an initial peace agreement, there was violence and fighting that broke out. And I was able to work with organizations that were on the ground, that were working quite actively and collected a lot of data which looked primarily at peace and security. And I've been looking broadly at peace and security, but within that, looked at trauma and mental health. The methods that I used for this study were classical test theory, item response theory, differential item functioning, and structural equation modeling. But I'd like to give just an overview of some of the findings that we saw. So the study was done in Malakal, which is a region in the Upper Nile state. As I'd mentioned, this was the South Sudan Law Society because the study looked more at transitional justice and healing and reconciliation. I've worked a lot with interdisciplinary teams because this is something that came up, but really in humanitarian context, it's such a concentrated effort, which is interdisciplinary. You have several organizations across various fields working together. So, we don't have mental health siloed, but working across health, across social protection, across child protection, across security and law as well. And, organizations coming together to work across these topics. So we'd worked in this UN Protection of Civilians campsite and looked at adults, primarily South Sudanese nationals, but also looked at internally displaced and refugee populations. The sample size was 1,200 adults, but this is part of a bigger study. And we also looked at data specifically around sexual and gender-based violence as well in other parts of South Sudan. But for these papers, I'd looked at this sample, and there was an ethnic distribution across Dinka, Nuer, and Shilluk populations, which people who might know about the ethnicity of people in South Sudan might know that these are the primary ones, and there was a lot of infighting that happened between them. So we looked at household service survey data, and this is one of the publications that came out of it in 2015, but I'll also show some other publications that we've done with this work. So broadly, we looked at using the Harvard Trauma Questionnaire, which is one that I've used across several studies, but more recently I've been working with the LEC, which is another measure of trauma. We looked at several traumatic events, and it's really quite disheartening when you look at this data. I mean, these are data points, but these are represented by real people. So we saw this is common actually that we found across settings, but a lot of almost 84% of the population reporting that there was destruction of property, there was destruction of assets. A really high percentage of people reporting that they've seen close family members being killed. Witnessing of killing of family and friends was really common. Exposure to war-related fighting is something that's come up as a theme in several contexts that I've looked across. So really quite disheartening data where such, it's so commonplace to experience a lot of these events. We did also see in smaller proportions sexual violence, but this was something that was considered extremely traumatic by the people who reported it. And there might have been some underreporting because of the specific security concerns as well, which I'll talk about. So I'd also, again, I'm providing snapshots. These are detailed studies, and I'd be happy to point you in the direction of some of these publications, but we looked across men and women. And you'll see that some of these traumatic events were reported more by women, specifically around sexual violence. But we also saw, and also things like destruction of property, and killing of close family members, but we also saw that men reported more forced recruitment, more exposure to war-related fighting, more combat and injury and death threats. And part of the study was also seeing if there were significant differences. And one of the methods that I'd used was differential item functioning, which I'm happy to talk about, but we saw that some of these items really differed across men and women, and how trauma was experienced and the impact that it had on the mental health of men and women as well was different. So it really points to a gender-based analysis as well when we look at trauma. This data was also really helpful because we were able to see how many times people reported various traumatic events. Specifically, you'll see that things like exposure to war-related fighting, obviously, if you're in an active war zone, it's going to be reported much more. So these green bars are 6 to 10 times, so the people could actually say how many times they experienced something, or how many times they were both exposed to or witnessed certain events. And again, we're seeing a lot of destruction of property, destruction of homes, which is really disheartening, but also a lot of torture that took place. And this, I'll talk a little bit about the differences between quantitative and qualitative data, but I think one of the drawbacks of quantitative measures like the Harvard Trauma Questionnaire, LEC, or some of these other checklists is that you can't really get much, you can't get as much detail as you want on what sorts of trauma these were and how they impact other outcomes as well. But we're seeing a large amount of reporting of kidnapping as well, of having family members disappear, of rape. So I also use item response theory. Again, some people in the department might be familiar with this method, but it's a really nice method to be able to see what the underlying trait is. In this case, we looked at war-related trauma as the underlying trait, and to be able to understand how much different items contribute to that underlying trait. So I'm not going to go into the details of that method right now, but happy to talk more afterwards. In this case, there are some, there's some drawbacks of using item response theory for checklists like trauma events or stressful life events. But in this case, we did see that some events were, or some traumatic items were much more sensitive to picking up the underlying trait, in this case, trauma. And what the higher curves tell you is how sensitive it is to picking up the underlying traits. So we're seeing that witnessing the killing of a close family member, along with having close family members being killed or being threatened with death, were really sensitive to the underlying trait of war-related trauma. And this is something that I also use to make recommendations around. If you have to focus on a few things in this context, these are some of the items that are really important to keep because they're really telling you a lot of information about what's going on. Again, this is a lot of work, but just providing a snapshot of what we did. Another study building on this was looking at whether being a combatant in the war was associated with the risk for post-traumatic stress disorder, as well as perceived security in this campsite that people were being sampled from, and whether war-related trauma was actually a mediator of some of these associations. And this was really important. This is an important question to see because we talk a lot about people who've faced a lot of hardships, people who've been exposed to a lot of traumatic events, but there's a lot of literature on both perpetrators and victims of violence as well. And what this allowed us to see is if someone was reporting being a combatant in the war, is that more likely either a current soldier or a former or an ex sort of former soldier in the war, was that associated with experiencing more trauma or experiencing higher risk for post-traumatic stress? This also had implications for how a lot of the peace and reconciliation activities happen, many of which are focused on working with both victims and perpetrators. So seeing if there might be perceptions of security within the campsite. And as we worked on other studies, especially in DRC, where we're looking at, we looked at justice and healing, what it really means to be, to have experienced war-related trauma, both as victim and both as someone who's perpetrated it. So here, what this broadly shows us is that people who fought in the war experience certain kinds of traumas. And the paper that I'm happy to point you to gives more details of the kind of traumas that combatants experience versus those who were not, and how they might feel secure or insecure about being with others in the same physical location, and how this might impact PTSD risk. Another thing that we found with the study was ethnicity also impacted, because and I talk a lot about the importance of recognizing local context, but in this case as well, understanding the conflict dynamics is really important, especially for a lot of organizations that are coming in for foreign aid or trying to do any sort of restorative work. It's really important to understand what might be going on outside of just seeing that someone experienced trauma or that someone's requiring mental health services. And again, with all these studies, I try to look both at men and women as well in subsamples, specifically to see if there are any moderation effects as well. And what we did find was that we saw similar patterns for men, but within women, we saw that there was evidence for mediation through trauma, and almost entirely mediated through trauma, where women combatants in the war experience greater risk for PTSD, but also lesser perceived security because of the trauma they experienced. Sorry, I think this is being cut off at the top, but this is a slide which just shows the participants in our study sample who met the clinical criteria for post-traumatic stress disorder, which is fairly high, it's 53%. This could also be a function of, people having experienced a lot of trauma and being asked about it immediately after they experienced it or during, because this was fairly soon after a lot of conflict had taken place. But it points to how there's a lot of need for mental health services in these populations as well, but very little that's actually being delivered. And this slide is actually really helpful because it allows us to see the question that was asked was, whom would you speak to about your traumatic experiences? And most people reported speaking to family members. So that's 36% of the sample, but a lot of people also reported speaking to or wanting to speak to religious leaders or traditional healers, which points to the importance of working with community members, specifically religious leaders and traditional healers and family members within the community, because there is less access or less perceived access to mental health care. And there's also a lot of literature around spirituality and religion and coping for mental health, and the role that religious institutions play. So there's a lot of interesting literature around this as well, especially for people exposed to mass conflict. So some of the key messages that came out of this were that there's a high percentage of people experiencing trauma. And I've talked about some of the specifics of how these items perform, but which is more technical, but overall, what's recommended is having more security in the settlements, especially where people feel there's less perceived security, but also the importance of having gender-sensitive services and care, especially gender-sensitive assessment as well, especially when health workers are going in and asking people about their trauma, being vigilant that men and women might be experiencing different types of trauma. And the importance of community-based programs in building communal interconnectedness, especially when working with both perpetrators and victims of violence. So this is the publication that came out of this work, and we have another one that we've submitted as well, but happy to share some of these details after the talk. So I'll now move on to a qualitative study which looked at how trauma has been culturally understood in Liberia, so more to the west of the continent. This is just some background on the Liberian civil wars. Again, thousands of people who were refugees who died during the civil wars, over 1 million people displaced, and through some very limited studies, found really high prevalence rates of depression, MDDs, major depressive disorder, and post-traumatic stress disorder. But Liberia is also known as one of the countries that has very limited mental health services. Apologies. For the longest time, there was the statistic that there's one psychiatrist in all of Liberia. I think that's changed now, but this is a context where we're seeing limited services. So this is a study that was done by the MGH Division of Global Psychiatry. We used key informant interviews with 43 Liberian adults, and they were asked to think of someone who's still suffering from the war and someone who's recovered, what the traumatic events they experienced were, and what might be some of the indicators of both suffering and resilience. So I worked on the trauma piece, but I've also done some content and thematic analysis around some of the coping mechanisms that people used. So here I'm presenting some of the key themes that came out of the content analysis. This is a word cloud of things that were prominently reported. Again, this is a qualitative study, so this isn't prevalence data, but it really gave a lot more context to some of the experiences that people described in quite graphic detail. But people talked about some of the abuse that they went through: sexual, emotional, physical, captivity, being a combatant, again, something we talked about with the previous study, some of the killings that they witnessed and experienced and perpetrated, physical health and injury, but also resource loss, which is a big theme that's come up across several studies, and specific themes that came up around the war environment, which were really relevant to the Liberian context. And this is a slide that shows when you compare something like the scale that we used in the previous study, and that's also been used in Liberia, which only captures these, this snapshot of traumatic events. But with the qualitative data that we used, we were able to understand so much more about what happened, and some that were really specific to the Liberian civil wars. There was some really horrific things, obviously, to read about, but a lot of forced cannibalism, a lot of humiliation and ethnic discrimination which took place, which again is really helpful to understand more about the specific context and why some people might be suffering still from the effects of the war, and some might have recovered. And I'm happy to also share some of those findings, but we saw that there were combinations of factors, things like age and sex, but also where people lived and the kind of trauma that they've been through that really helped them either recover or kind of kept them, stuck in that cycle of suffering, despite access to services and aid. So one of the key take-home messages from this work was how Western diagnoses and some of the scales that we commonly use, especially in sub-Saharan Africa, might not be able to capture the rich array of local conceptualizations of trauma, of mental health, of symptoms. But we're seeing a lot more studies coming out on these topics, and a lot of mixed methods work that's able to capture so much more than just quantitative data. And I like to discuss this example of the open mole, which is again a symptom that people discussed, and it came up in some of the interviews as well. It's like a softness in the head that people talked about, and doctors were not able to find any physiological basis, but soon understood that it was commonly seen as a symptom of trauma and of stress. And understanding some of these local idioms is really important, especially when service providers are doing assessment or trying to develop interventions in countries where there might be a lot more to understand and unpack when it comes to trauma and mental health. So the key recommendations that I've also talked about is using anthropological research, using cultural adaptations of Western measurement and screening tools. It's something that we're commonly doing much more in our work as well. And working with local staff, and also working with traditional healers and community leaders in providing care. And then finally, I'll bring up this study that I'd done a while ago with a team that was also working at Harvard, but is now at Boston College. And this looked at the role of risk and protective factors, specifically coping. So moving towards the protective factors a little bit more. And this was a study that was done in Sierra Leone. Again, a country that had a history of civil wars. This was longitudinal data that we worked with, which was collected across 3 time points. And the population was primarily adolescents, sampled across 5 districts in Sierra Leone. We used door-to-door random sampling and collected data on a wide variety of indicators. But this study specifically looked at the role of coping as a mediator between war-related trauma and mental health outcomes. And we have mental health outcomes at various time points. So that was used as a covariate. But what was interesting was this idea, and we used the brief COPE scale, but it captures different coping mechanisms. And theoretically, these have been looked at as approach coping and avoidance coping. Approach coping is more around planning ahead, problem solving, seeking support, whereas avoidance coping might be tools like distraction, denial, escape. What's interesting is these have been commonly termed as positive and negative types of coping in the literature, but it's not necessarily that black and white, because many of these are not mutually exclusive, they overlap, but at different points in people's lives, some might be more adaptive than others. And what we found was that when events are seen or when trauma is seen as controllable, then approach strategies might be more effective. But when something like war-related trauma, something that was traumatic and happened to you, but you can't do much about it, some of the avoidance coping strategies might be more effective in long-term mental health outcomes. And this isn't to say that something like substance use or escape might be more effective, but trying to work with some of these strategies, especially trying to channel from distraction and escape towards more approach coping strategies might be useful for more long-term resilience building. And also trying to work with people who've experienced a lot of trauma, but helping to externalize some events and blame instead of internalizing them might be a useful strategy. So these are some of the key recommendations that came out of it. And this is the paper again. Happy to share the link with you as well. And just to touch on some of the work that I'm doing right now with Professor Karsten Conan in the EPI department and NeuroGap psychosis study. So we're looking at the role of daily stressors in mediating the association between trauma and mental health. This is, again, something that's been stressed a lot, how quite often we only look at an indexed traumatic event and look at mental health outcomes, but it's really important to look at trauma response and the whole sort of trajectory of what people experience. So the study was done during the COVID-19 pandemic. So we were able to collect data on COVID-19 stressors, specifically things like worry that people have about their family members' health and their own health, or information that they're receiving from the media and misinformation as well, about isolation, about the economic consequences, about food shortage. And what we saw, we've just submitted this paper as well. So hope to share the publication with you. But broadly, the findings do show that daily stressors play a huge role in exacerbating previous trauma and sort of exacerbating some of the mental health symptoms that people might be experiencing. This is a case control study. So we were working with cases, people who have severe mental illness, specifically psychosis. And we did see that, there were greater symptoms in people who had previous mental health issues, but also people who were already at risk, people who had physical health conditions. Their mental health was also affected by daily stressors. So something to keep in mind again as we think about intervention strategies. And because this talk talks about, is covering sort of broad issues of working in humanitarian settings, I thought I'd also spend the last few slides talking about some of the challenges of working in humanitarian settings and how I've tried to work on overcoming these, and some of the teams that I've worked with have been really creative, but these are issues that a lot of us might face, specifically around the lack of having a very clear sampling frame. So this is something that came up a lot in the work that I'd done in DRC, where political borders were constantly changing, and because it was a repeated cross-section study, but unit of analysis were the villages that we worked with. When there was a high percentage of mobile populations that were constantly moving. Things were changing on the political front quite often. It's really difficult to have that sampling frame. So we developed methods where we worked with local actors and had a really strong presence on the ground, tracking these changes as well, and used a lot of new innovative digital methods for tracking and kind of overcoming some of these challenges. But there's also challenges around physical security. Again, really important to make sure that the security of the data collectors, the field staff, everything comes first. So we had protocols in place to make sure people, especially working in active war zones or places that have epidemic outbreaks as well, their physical security is guaranteed. But also the people that we work with, so the subjects and the participants, really important to make sure that the questions that we ask are not triggering and not re-traumatizing for people. So making them brief, just really trying to cover the really useful information without, without over sort of asking too many sensitive issues, and making sure their referral systems as well, if their mental health is being, in question at any point. Political implications of working with donors, working with aid organizations. Usually those are the ones that fund. So making sure that the data that's shared is also shared in a sensitive manner. And again, logistical difficulties have to do with security, but also have to do with the challenges of transporting tablets for data collection, or making sure internet is working, working with mobile populations who are moving constantly. This is where longitudinal studies become really challenging, but the way to work around that is either having ways of following up with people, or making sure the unit of analysis is much more defined. Groups that are hidden, that are inaccessible. Again, for this, it was really helpful for us across studies to work with local actors to make sure the trust can be established in data collection, and providing as much informed consent and information as needed, and giving people the choice to opt out whenever they don't feel comfortable. And all of this has to do with ensuring confidentiality, working with local capacity. So one of the things that comes up really often is that there are competing priorities in humanitarian contexts. So mental health is just one of them, but it's not always the primary one, because the health and security and protection is what needs to be guaranteed first. But I think this is why it's really great that we're seeing much more integrated efforts, and just making sure that mental health is combined with other services as well. So it's also an efficient, a cost-effective use of services with limited resources, places with limited resources. Also, a lot of migration and displacement that happens with populations in humanitarian settings, and trying to capture data, but making sure that you're not overburdening people that already are dealing with a lot of issues in daily life and survival issues. So finding that balance between asking the right questions, but also linking with service provision and pointing them towards the right kind of care. So some of the solutions are integrating programming, especially around mental health, along with other services. In some of the work that I've done in Rwanda, we used human-centered design, which helped in, so it's working with the population that you're trying to, that are going to be the beneficiaries of the work that you do, to ideate rapidly and try and come up with prototypes and solutions for interventions. It's a method that's gaining a lot more coverage now, but it's also helpful and rooted in community-based participatory methodology. And then finally, just making sure that we're integrating services in a way that the social considerations and basic services are taken care of. community and family systems are supported, and then moving towards more specialized services, again, in places that have very limited resources and might not have specialized services. So there's a lot of really great evidence on task shifting where healthcare workers are trained, or community workers or teachers in schools are being trained a lot more in at least assessment and diagnosis, or linking with referral services as well. So I'd like to end with saying that I think one of the things that guides some of my work is that there's no concept without context. So really trying to understand what the local context is in any of the work that you do. And this also means encouraging more research and capacity building from researchers in the countries that we work in, who have a lot of a wealth of knowledge about what's been going on and have been seeing this over years. So in the work that we're doing now under NeuroGap Psychosis, we're working with psychiatrists, with healthcare workers, with researchers in Ethiopia, Kenya, Uganda, South Africa, and also, having them lead some of this work, because it really kind of comes from the voices that haven't been heard a lot. And the Ebola example is one that just touches on the importance of again, local context, where a lot of the qualitative and anthropological research helped understand what might be some of the factors that are leading to more deaths, and family members feeling like they were not part of the burial services. So research was really helpful in uncovering some of these issues, and helped in curb the spread of the virus by having community leaders work with healthcare workers, work with family members in assessment and diagnosis, but also providing care, especially to family members who might have been impacted. So I'll end here and stop sharing, but yeah, turn over to you. Any questions?